Good morning. Joining with today is Keith Meldrum from Kelowna in British Columbia. I finally got that right. It's not Vancouver. Vancouver is
Yeah,
not all of British Columbia.
correct.
And what I like to see, we've been chatting for a while, and last time we talked, and it was pretty much really poor Wi-Fi here, and
Right.
people keep getting dropped. So we're trying this again. Hopefully, this won't happen again. So, Keith, tell us a little bit about yourself and how you got involved with the pain group here on social media.
Sure thing. Well, thanks for having me, Nick. Appreciate this. So, as you said, my name's Keith Meldrum. I live in Kelowna, which is in the southern interior of British Columbia. My day job is I'm a deputy fire chief with the municipal fire department here in Kelowna. And my introduction to pain, for lack of a better term, goes back many years to August of 1986, when I was a young teenager, 16 years old, made some pretty bad decisions. Despite being given all the tools by my parents to make good decisions, I chose not to. Went out with some friends from work. We went camping, stayed up all night. There was a certain amount of alcohol involved, and I was too young and naive to know that you can't basically get no sleep. I had about an hour's worth of sleep, and alcohol you'll fall asleep driving your car is what happened.
Wow.
I was driving back into town where I lived. I was out in a rural area at the time, and again, I just fell asleep behind the wheel and rolled my car down a bank end over end. And I was only wearing a lap belt. It was an older car, shoulder belt, and I was literally torn in half internally by the lap belt. So I tore through my abdominal wall, my largest small bowel, and just
Wow.
so that was something that nearly killed me. Very fortunate that people saw me leave the highway because I was down a bank. And short version of the story is within an hour, I was able to get to a trauma center and undergo the initial 7 hours of emergency surgery process.
Okay.
So lots of surgeries over the year, things put in, things taken out. And back in the 80s and 90s, chronic pain was really not well understood. Medicine was very good with mechanical stuff, so they would open it up. But it came to a point where they were lost. They were like, everything that's broken, we have fixed. We put stuff in you, but I still had pain. And for about 20 years, I kept looking for an answer and really fighting my way through it. It was really angry, a lot of anger, because I was trying to fix me. And because I wasn't given any of the tools to understand the complexities of this world of chronic pain. So it wasn't until 2005 when I was referred to a medical center in Vancouver for technology called spinal cord stimulation. And that was my first introduction to not only a biomechanical solution, but the first time anybody opened the door about this whole body-mind connection. And that was the beginning of me realizing this is much more complex than just a biomechanical issue. To understand more about how I needed to work better for myself. I had a role in my self-management. Sort of my outlook on my healthcare played a huge role in how I felt. And I just really started to light the fire about there's more that I can do to help myself and then ultimately help others as well. So.
Okay, that makes sense.
So that's kind of, I was going to say that's kind of 30 plus years in a nutshell. And in fact, it's still something I deal with. I'm just about 2 weeks post-op. Again, I had 2 more revision surgeries just in the last few weeks because this is something that will continue to be part of my life, both biomechanically and psychologically, socially, emotionally, all of those things. So.
Yeah. Wow, that's a lot to take in for 30 years. So you just have to go back and get cut open every once in a while just to.
Yep, I had in 2015 the implanted medical equipment needed to be changed out. It was just end of life.
Makes sense.
Yeah.
Mhm.
And ever since then, we've had some challenges getting the efficacy of it to sort of increase. And
Mhm.
so I was just recently in Vancouver for a couple more revision surgeries where they were trying new technology and a few other things. So yeah.
Wow. So how long does battery last in your spinal cord stimulator?
So the ones that I have, they have about a 9 year service life, for lack of a better term. Yeah.
Okay. Oh, okay. Is this
Yeah.
similar to, are you familiar with CRPS? Is this very similar to what CRPS patients undergo?
I'm not too sure. I am familiar with CRPS. My
Mhm.
pain is neuropathic pain, left abdominal wall, just from all the trauma.
Okay.
And the spinal cord stimulation in recent studies have shown that it's really quite effective for people that have distal limb pain. So for somebody like me that has trunk and abdominal pain, certainly a bit more of a complex case, but I have an incredible medical team that is very focused and helpful on me to help
Okay.
me.
Good.
Um, but so neuropathic pain, the intent is, just people have like phantom limb pain. They had it's the same kind of idea. The nerves are still saying, I have pain, which is being processed by the brain, even though there's nothing there really to say it's broken. So it's a way to it's a tool to help manage that, by getting into your brain and just helping override that pain signal, really. It's the simplest
Wow.
term.
Okay.
Yeah. Yeah.
Okay. That's good to hear, though. Thank you for sharing that.
Yeah.
And how did you get involved with IASP actually? Excuse me.
A number of years ago, 7 years ago, I started really turning my focus to pain advocacy and more so on the patient side. Because of my experience in the 80s and 90s of having no patient support, nobody, again, very good biomechanical support. Let's cut you open, let's try and fix something, but no tools given on how to help myself. And I realized that's a huge gap, massive gap.
Mhm.
It's you're not treating an inanimate object. You're treating a person with feelings and emotions and a past and a history and a story. And I
Mhm.
realized there was a loss there. So I started to work with an organization in British Columbia called Pain BC.
Okay.
We're it is a leading advocacy and education group. It's got a really strong presence in Canada. Um, and that helped relight my fire for making sure the patient voice is really heard. So fast forward to IASP, I was communicating with my online friend Joe Belton, who
Mhm.
I haven't met yet in person, but I just have so much respect for Joe. We did a podcast with Mark Cargella, and we were talking afterwards, and she said, IASP this year,
Mhm.
great lineup, what a wonderful group, no patient focus. And I
Mhm.
was like the whole foundation for chronic pain is the patient. It's like taking your car to the mechanic, but not talking about the car. It's what you're there for.
Yeah.
So I just reached out to ISP and said, amazing work that you guys are doing, like nobody better than you. But I said, I would offer you would find more effective treatments and being able to help people if you had a patient focus. Just planted the seed. And the CEO of ISP reached out to me a week later and said, oddly enough, good timing. We have funding this year to do a patient panel to develop a framework for a patient engagement, and invited me to participate. So just very good timing. Mm-hmm.
Okay. Will you be the only patient there to speak?
No, so they've got their goal is to bring 20 people with the lived experience from sort of around the world or North America to
Okay.
work with IASP to help them develop this patient-focused or patient-centric framework. So part of my role in agreeing to go to the World Congress and sort of be there and present is to be a participant to help develop this initial framework, which for me is nothing more exciting than being able to help IASP develop a patient-centered framework. So,
Okay, that's good. Now,
yeah.
how would this, in in this case, or how do you think? I mean, let's put it for example here. If you were to see a clinician or any kind of doctor or a PT or even an RMT, what do you look for when you go see one?
So what I look for now as compared to what I look for before is completely different. That's for sure.
Yeah. Can you tell us the difference between that? That's a good one.
Absolutely. Before I started to realize the complexities of chronic pain and the biopsychosocial model, I, I was looking for, I was really looking for the panacea. I had it in my head that there was a solution out there. I just needed to find the
Mhm.
right medical professional who would push that button or do the right procedure, and all of a sudden I would be better. Once I
Okay.
realized that's not how this works, I needed to develop a community of clinicians and healthcare providers that could work with me, and that would be, psychologists, RMTs, chiros, movement specialists, whatever they are, that can engage with me and help me also help myself. So it's not all about me coming to you and saying, geez, Nicholas, here's my problem. I need you to fix me. It's coming and saying, here's my problem. Here's my story. Here's how I feel. Here's how it makes me feel. And there's a lot of complexity to that. And sometimes that's a lot to unload on somebody. But I think it's important to be able to share that story and then work together to say, okay, here's what you can do for me, but as importantly, here's what I can do for myself. Because if I don't bring my part to this and I don't do what you said, okay, here's, Keith, you really need to do this. You need to try that. If I don't bring that, the chances of success of having a better life are much less.
Yeah, got it. Makes sense there. So,
Yeah.
yeah, because what I've been hearing a lot in the last couple of years, even going back to way back in the 2000s when I used to be a personal trainer for more than 12
Yeah.
years, and there was a mentality that there will be one person who will save you, who will save that person from chronic pain. Because I
Yeah.
have a magic special technique or some kind of gadget or a system
Yeah.
that is going to wipe that low back pain away or the knee pain away from you. But
Yeah.
that's not true. So,
It isn't, and I fell. I'll say I fell into that trap, and I don't know if it's a trap as much as, like you said, that's just sort of the way the medical system and pain was looked at it that way. And for me, I kept
mhm,
my focus was on surgical solutions because again, my
got it.
issue was trauma from a car accident trauma. So I was initially put back together. I had a temporary colostomy. I was so damaged it needed to be reversed, and then I had other surgeries and a hernia repair with mesh because I have no left abdominal muscles anymore. So
Mhm.
my world was centered on I would go to a surgeon. A surgeon would cut me open and fix me. So I kept looking or assuming there was a surgeon out there who had the next golden scalpel, and I just hadn't found the right one yet.
Got it.
That's a tremendous amount of responsibility to put on one person when it's not possible. And with all due respect, there's a lot of surgeons. This is painting them with a broad brush, who felt that if they didn't have the solution, then there was no solution.
There was it's pretty much throughout everything, everywhere. Every PTs, RMTs, and maybe a couple of other healthcare professionals too, even trainers as well who works at a gym. Don't have a solution for whatever health goals you have, then you are forever going to be a broken mess. So
Yeah, and
I've been there, done that.
well, and it's and I think that's part of what we need to bring to the healthcare world is to let clinicians know that it's not only okay, but it's really their responsibility to be able to say, I don't know, I don't have all the answers, but working together in this multidisciplinary system, the right supports, as a team, we can work you to have the best life you can. And that'll be anywhere from, for some people, they're able to work through whatever their pain mechanism is to maybe resolving that pain or having it much less. Or for somebody like me, living the best life that I can. Pain will always be a part of it, but it doesn't need to be the thing that will take
Hold on a second, Keith. We kind of lost you there. Can you hear me?
Yep, I can hear you.
Sorry, but the bus went by. It just kind of like rumbled everything out what you just said. So
it was basically, it's just letting clinicians know that it's okay to be able to say, I don't have all the answers. I'm not the magic solution maker, but together with a team, we can find ways for you to live the best life you can. Because it's a tremendous amount of responsibility to come and drop at your feet and say, okay, you need to fix me. It's not reasonable and not practical.
yeah. Yeah, from a patient's perspective, I mean, usually I would ask this for a lot of my colleagues and friends who are in the healthcare profession. How would you, let's say you have a family friend or a family member who has a similar type of chronic pain you have, and they have this mentality also that they're going to have one single solution is going to help them all. And how would you address that? As
if there was they were looking for a single solution?
Yeah, they have kind of like what you have with the surgeon with a golden scalpel.
Yeah. So and again, through my experiences, and I've seen this with others that I've had an opportunity to talk to, is, and it's really very complex. And it's still learning so much, but from my experience, as the patient, you need to be in a place in your life where you can accept that there isn't any single solution. And everybody gets to that place differently. It took me about 20 years to get there. That's a long time. A lot of that was stubbornness on my part. But the best counsel that I could give somebody is, if you look for a single solution, you will continue to look and probably, and I say probably, never find that single solution. So you need to take a step back. You need to look at somebody's health issue holistically and help them understand that this isn't about just a biomechanical issue, because it might not be, and quite often it isn't. You know better than I do that somebody's pain, there might not actually be a structural deficit or something that's wrong, but they're still having pain. So it's getting that broader picture and saying the value in trying to find a single solution, you will burn up a ton of energy and not find that solution as compared to let's look at other ways of helping yourself. And I will stress till the day I have no breath left in me is we as patients have a responsibility to help ourselves as much as we can as well.
Makes sense. That's really good though. Well, we're almost out of time here, and also going to have a very, very humble here to hear from your side of the story. Now, how long? Now, I am actually going to the IASP conference coming up in mid-September in Boston, Massachusetts, and I've never been to a conference like that before. In my head, it's going to be like a TED Talk or something similar to Pain Cloud, where I went to Norway last April. Right. So I'm wondering about how long will your presentation going to be, and how you're feeling about it. Just what were your thoughts?
So I'm still learning because this is very new for IASP. This is the first year they've had the patient panel or the patient focus. I just received the information last week about sort of the date, so I'm not exactly sure what it will look like. My hope is there's an opportunity for those with the lived experience have an opportunity to speak directly to sort of the clinicians and the researchers and all these brilliant minds from around the world and have these kind of conversations, which, again, I'll take it a step back and I'll say, when I entered this world 30 years ago and where I lived, there was like no understanding of chronic pain. So I've seen how far we have come, even though it feels like at times we haven't made very good progress. My personal experiences, I've seen amazing progress because there's all these people doing this research. I think we need to make sure that we harness that energy and make sure it doesn't get lost on the fact that they're still the person. You need to understand their story. You need to understand the emotions and the fear and the anger and the grief and all that goes with it, because all of those emotions directly affect their pain as well. So my goal, my hope is to continue to lend my voice to be able to say, let's keep doing this great work in science and medicine and research because it's incredible. Never forget, it's all about the person sitting in front of you.
Yeah, that's very true. That's very awesome, man. Storytelling there. For those of you who have no idea where Kelowna is in British Columbia, it's I haven't looked up on Google Map yet, but in my head it's like a little valley in the middle of the province where there's a lot of wine, mountains, and hiking involved.
Absolutely. Yep. Yeah. About 4 hours north of Vancouver.
4 hour drive. Oh, wow.
Yep.
Is there a train that goes there or public transportation that goes there?
Unfortunately, no train. A great highway system or a 45-minute flight.
45-minute flight. Well, so we'll see about that someday. So.
Right on.
Well, thank you guys. Yeah, Keith, thank you very much for your time, and hopefully I'll see you again over in 2 months over in Boston. And if you haven't checked it out, I'd like to give the opportunity to give a little thank you to Sandy Hilton, Sarah Hay, and Karen Litzy and Ellie Summers, because they are the ones who kind of got me involved with this little improvised, video conferences here, which I would want to do for many months already. And also with Taylor James from from Vancouver, who was very awesome, who got me motivated as well. So thank you guys, ladies and gentlemen. So thank you, Keith, for your part. Yes, what's up?
I would like to thank you. I think things like what you're doing, every brick in the wall helps build, the foundation that we need to continue to raise the awareness of chronic pain. And again, like I said, my focus is that patient-centered focus, which I know, yourself and Taylor in his talk, they talked about, bringing it back to the patient. And I'm just very appreciative of what you've done and giving me the opportunity to speak with you.
Thank you, Keith. All right. So I'll see you later. Take care, guys.
Thanks. Bye.